So welcome everyone. This is a special series that we bring to you. This is now the third episode. Dr. Weissman and today Dr. Adam Atoot. He is the Transitional Year Program Director at Hackensack. And what we do in this educational series is they walk you through either cases or some bread and butter issues that you will see as residents, number one. And number two, it can help you in your rotations and also during your interview process. So that's the idea. He'll walk you through some cases, and then we'll open up for Q&A. I'll also talk about some of the other things that Dr. Atoot graciously does for us to help IMGs. So with that, over to you, Dr. Atoot.
Okay, perfect. Thank you so much. Let me just share my slide. Okay. All right. Can you see my slides?
Yes. Yes.
Oh, excellent. So first of all, thank you everybody for joining us today. Poam has been gracious enough to invite me to do a quick, maybe 15-20-minute conversation with you guys about just some EKG interpretation. Hopefully we'll keep going with this series in order to get you guys more prepared for residency, and then when you guys do rotations in different places. EKG, obviously, guys, is a very, very, very important topic. Most of you are applying for residency this year. So as an intern coming in, there's a lot that you need to be aware of especially when you're on night float or when you're in the ED rotation, how to interpret EKGs. Now, it's a very, very large topic, so I'm not going to be able to go over absolutely everything today. It's just going to be like quick touch points. We'll start with the very, very basics. I didn't know who I was lecturing to today, if it was mostly like early on medical students or people who are applying. So I kind of put a little bit of basics in the beginning and then complexity at the end. So let's kind of just go through this really quickly. When it comes to the EKG, guys, you have to think of it as a different representation of different points in the cardiac cycle. And each time in a normal physiological heart, you have the P wave, which is atrial depolarization, then the QRS, which is ventricular depolarization, and obviously the T wave, which is your ventricular repolarization. So anytime you have pathology within that cycle, there's different things that will pop up in the EKG, and you have to be able to interpret that. So the way that you're going to be interpreting it really depends on who teaches it to you. I'm going to teach it to you how I was taught it, and I find it to be quite easy. It's not the only method. There are many other methods to go over, but this is generally how I remember it. So first thing I like to do is I like to identify the rate, the rhythm, the axis, and then I look at the intervals and then the morphology. And if I go in this order, obviously, somebody like me who's been doing it for a while, I can do it very quickly. I might be able to speed up. If you're starting in the beginning, I highly recommend you go through these steps one by one. Don't skip one, only because it's very easy to kind of get overwhelmed with the amount of information. And then if you get out of the habit of doing all of these things, you're going to miss small details. And what I tend to see is people start to diagnose the 3 or 4 things they feel comfortable with rather than the EKG as a whole. Okay. So how do we get a 12-lead EKG? Well, it's 4 limb leads that you could see on the right arm, the left arm, right leg, left leg, and 6 chest electrodes. Okay. So from these electrodes, we're able to generate 12 leads. Okay. So this is what it would normally look like. Obviously, you guys all know that, right? So you have lead 1, 2, 3, AVR, AVL, AVF, V1, 2, 3, V4, V5, V6. Lead AVR is the only one that should be negatively deflected normally, because if we look back on this, you notice that it's the only one that's away from the axis. So AVR should always be negative. So a common question that I tend to ask my residents, somebody comes in with chest pain, a lot of them, they know that T-wave inversions are generally ischemic in certain instances. And so I usually ask them, hey, look at this EKG, and somebody will point out, oh, there's T-wave inversions in AVR. And they may think that that is ischemic. Remember, AVR should be negative the way it's listed here. So being negative is normal. If it's positive, that's actually abnormal, right? It means either they reverse the leads or there might be ischemic changes if it's reciprocal with the other leads. But generally, make sure to understand AVR should be deflected. That is normal. Everything else should be positive. I also break down the EKG into its anatomy, if you will, right? So if you don't look at it like this, you're going to confuse non-specific changes for ischemic changes. So what do we mean by that? When we divide the EKG, you have to divide them into its lateral leads. So that would be lead 1 and AVL, V5, V6. You have to divide them into their inferior leads, 2, 3, and AVF. And then the anterior and septal leads, which is V1, V2, V3, V4. Okay, you have to do it like this, because if you don't do it like this, you're going to run into scenarios where there might be some changes in, let's say, V1 and some changes in AVL. They may look potentially ischemic to you, like let's say T-wave inversions in V1 and AVL. And if you don't know that those are not in the same territory, you might think, oh, there's some ischemia here, but in reality, there's just non-specific changes. So for example, if you see ST depressions in V1 and AVL, we call that non-specific ST changes. But if I see ST depressions in concordant leads, let's say 2 and 3, and I see ST depressions or ST elevations, I'm going to say there's inferior wall ischemia here. Understood? And the other important thing, if you want to take it further, what I usually do too, is I associate the anatomy of the actual vessels with the leads. So if I'm talking about the inferior leads, I see an ST elevation in 2, 3, and AVF, I'm thinking that there is either an RCA lesion or a left circumflex lesion, depending on the anatomy, but mostly RCA, right? If I'm looking at the anterior leads, somebody has ST depressions in V1, V2, V4, those are concordant leads. I'm going to think that it's probably the LAD, okay? So if you think of it like this, you'll have a lot more information. So you might hear, your attending will say, this EKG shows ischemic changes in concordant leads. Notice it's not consecutive leads, it's concordant, meaning they don't have to be one after the other. They just have to be in the same anatomical area. So V3 and V1, they're concordant. 1 and V6 are lateral, they are concordant. If there's ischemic changes in both, that is consistent with lateral wall ischemia, okay? If you see ischemic changes in non-concordant leads, those are non-specific, okay? All right, so this is essentially the same thing: rate, rhythm, access, intervals, and morphology. Access is extremely important, and in my opinion, quite underutilized when I see residents reading the EKG. Access should be maybe the second or third thing you look at after rate or rhythm, because access deviation gives you a lot of information in the right clinical setting. So there's very easy ways to do this. It's called the quadrant method, okay? And simply, there's only 2 leads that you really need to look at. So lead 1 and AVF, okay? Because if we look back here, lead 1 and AVF form the right quadrant of the axis, where normal axis should be, okay? So if they're both positive, you have a normal axis. You don't have to worry about that. If lead 1 is positive and AVF is negative, this is left axis deviation. If lead 1 is negative and AVF is positive, this is right axis deviation, okay? That's going to make up the majority of deviations that you have. If they're both negative, however, that's the only situation where you are going to say that this EKG has extreme access. This makes up less than 5% of EKGs, so it's not the most common. So if this is the one that you don't know, I'm okay with that. But obviously, as you progress through residency, I want you to know it. But as an intern, I want you to know how to identify left axis and right axis using 1 and AVF. Extreme access, if you run into that situation, we take a look at lead 2. If lead 2 is negative, then it's left axis. If lead 2 is positive, then it's right axis, okay? But extreme axis is rare. Most of the time, you're going to see either left, right, or normal axis, and those are the only 2 leads you need to worry about. So why is this important? Like, even though they're non-specific, there are things that can cause left axis deviation and right axis deviation. So for example, left axis deviation can be from an inferior wall MI, left ventricular hypertrophy, left bundle branch block, pre-excitation, as in more Parkinson White. So if I see that, I start to look for those things, right? Right axis deviation. Somebody comes in, was on a long flight, comes in, is a little tachycardic and has some chest discomfort, and I see a right axis deviation. My mind starts to go towards PE in that case, right? Again, absence of right axis doesn't exclude PE, but if it's present, it certainly helps you, right? So you want to get as much information from the EKG as you can potentially get. So looking at right axis and left axis will help you, okay? Next is the rate, okay? So there's many ways that you can calculate the rate. But I think it's important that you understand what the rate is, what each box is representing. So each one of these very small boxes is about 1 millimeter or 40 milliseconds. Okay, so that means each big box has 5 small boxes, 40 milliseconds, which means every large box is 200 milliseconds. So for you, if you look, if 5 boxes in a row essentially make up a second, which so for you, that means every 5 boxes, if there's a beat, that's 60 beats per minute. Okay, that's 60 boxes, and that means every beat, every 60 boxes is that. Now, the way I usually calculate it is I take a very easy shortcut. I count the amount of boxes between each RR interval. So that's the peaks of these QRSs. And I say, okay, there's 1, 2, 3, 4, 5, and I divide 300 by that number. So 300 divided by the number of large boxes will give me the ventricular rate. Okay. There are other ways to do it, but I find that to be the easiest, just the easiest shortcut for me. Okay. So here, if we count between the second QRS and the third QRS, there's 1, 2, 3, 4, 5 boxes. 300 divided by 5 is 60. So the ventricular rate here is about 60. Okay. Okay. Next thing, after I determine the rates, okay, next I look at the rhythm. Okay. So I ask myself, is this sinus? Is this regular? So what does sinus mean? That means the RR intervals are regular. The time period between them is exactly the same every single time. The atrial beat is conducted before every ventricular beat, which means I should see a P wave before every single QRS. So I look, RR intervals normal. Okay. This is regular. I look, is there a P wave behind every QRS? Yes. So this is sinus. And then that's the way you determine normal sinus rhythm. Now, what if the RR intervals are not regular, right? What if they are irregular? So then I ask myself, okay, they're irregular. That means the spaces are not the same. So you have to take a look and say, is it irregularly irregular or is it regularly irregular? So what does that mean? So I look at the spaces, and if they are different in an abnormal fashion, meaning there is no pattern. So the amount of the first boxes, first QRS, first R wave and second R wave, there's 2 boxes. Next one is 3, then 2, then 5, then 6. It's not following a pattern. It's just random every time. That's irregularly irregular, and that's usually atrial fibrillation. Okay. But if it's regularly irregular, meaning the QRS intervals the RR intervals are different each time, but they're predictable. So that means it goes 3 boxes, 2 boxes, 1 box, 3 boxes, 2 boxes, 1 box, and then so on and so forth. I can predict the pattern. That's a regularly irregular rhythm, and that suggests some form of AV block, usually second degree type 1. Okay. There are other types of vesicular blocks that can present like that, but generally, as long as you can tell me this is a regularly irregular rhythm, and I suspect AV block, that's good enough for me at this point. Okay. Next, I look at the P wave. Okay. So the P wave, guys, gives you a lot more information than simply saying it's sinus or not. Okay. The P wave, obviously, I think you all know this, represents atrial depolarization. The best lead to take a look at it is lead 2, in my opinion. It's usually very clear there. It's usually positive in leads 2. The duration is usually less than 120 milliseconds. The amplitude is extremely important. Okay. It should really not exceed more than 2.5 boxes of the small ones. Okay. Why is that important? Because as it exceeds that, I can tell you usually if there is left atrial dilation or right atrial dilation, depending on the morphology of the P wave. So if I see a bimodal P wave, it beats almost twice, like a camel hump, like you could see here in this picture. This is telling me that this is a dilated left atrium. That puts the patient at risk for rhythms like AFib, etc. Okay. And I might think, okay, why does a young person have left atrial dilation at the age of 20 or 30? Oh, they were maybe born outside. Did they maybe have rheumatic heart disease as a child? Oh, so maybe they have mitral stenosis. Let's do an echo to evaluate the mitral valve. Or somebody has a dilated right atrium who's a smoker. I might think, okay, did they develop emphysema? Have they had emphysema and COPD for a while? Is it causing maybe a cor pulmonale and enlarging the right side of the heart, therefore causing this right atrial dilation that I'm seeing? Let's do a echo to evaluate the right side of the heart, measure the pulmonary pressure. So you can easily get a lot more information as a diagnostician if you can pick up these small little details. Next is I look at the intervals. The first interval I look at is the PR interval. So this is the time the atrium conducts through the time the ventricle conducts. So I think most of you guys know first degree AV block, second degree AV block. I think that's pretty basic from med school. The PR interval will increase. Normally it should be under 200 milliseconds. If it's above that and nothing else, this is first degree AV block. And then obviously if there's conduction delay, meaning the ventricle drops, you can go into second degree or third degree, okay? The one that I tend to see a lot of residents miss is the opposite, not when the PR is prolonged, but when the PR is very short, okay? So when your PR is extremely short, there's not a lot of space between the atrial depolarization and the ventricular depolarization. That should hint to you, as somebody who's looking at the EKG, that there might be an accessory pathway, that it's not going through the AV node and slowing down appropriately. So for example, WPW presents like that. So if you guys pay attention to every delta wave you've seen that suggests WPW, there's usually a very short PR interval suggesting pre-excitation. So if you're first-year resident, somebody comes in syncopized, and you look at the EKG, and now it's normal sinus rhythm, but you notice that the PR interval is very short, that patient might have WPW and maybe potentially going into tachyarrhythmias that you're not catching right there and then. You might have to do a Holter to further evaluate, okay? Next, I look at the ventricular QRS. Okay, I look at the duration of it. So is it narrow complex or is it wide complex? Narrow complex generally means that it's being conducted from the atrium. The atrium conducts to the AV node and that conduction goes down to the ventricle. That's why it's narrow. If it's wide, it means that it's usually coming from the ventricle itself, or potentially there might be a conduction delay outside. So for example, if there's a left bundle branch block or a right bundle branch block where the QRS is not being conducted in a normal fashion, it takes longer. It has to go the other way around. And so the ventricle looks wider. For example, if you notice, every single patient that you've ever seen that has a pacemaker has a wide QRS. When the pacemaker paces them, it causes a wide QRS complex because it's not following the normal conduction. It's bypassing that. So it's essentially like a left bundle or a right bundle, okay? Okay, and then the king of the EKG, usually the one that I see most residents concentrating on are the ST segments, because most of the patients that you're going to see in the hospital or in the acute setting will be having some chest pain, okay? And so if you look, you have to identify what a STEMI looks like, okay? So ST segment elevation is defined as more than 2 millimeters rise in the ST segment. And you'll see that if they are in non-concordant leads, we say non-specific ST changes. If they are in concordant leads and they're elevated, that is a STEMI. That is what a STEMI is. It's 2 millimeter elevation in concordant leads, in at least 2 separate concordant leads. I always tell my residents too that they should always look for reciprocal changes in the opposite leads. So what does that mean? Okay, let's take a look at this EKG. Okay, so if we follow our recommendations of how to read it, we're going to say, okay, what's the rate? Let's count. I look at lead AVF. I look at the QRS there. 1, 2, 3, 4, 5. There's about 5 boxes between the RR interval. 300 divided by 5, that's a ventricular rate of about 60. Next, I look at the rhythm. Okay, are the RR intervals spaces regular? Yes. Are they preceded by P waves in all the leads? Yes. So therefore, this is a sinus regular rhythm. Okay, and then I look at the segments and the morphologies. P wave segments look fine. PR interval is 2 boxes, so it's fine. The QRS, you can argue maybe is a little bit widened here, but there's obviously very, very abnormal ST segment elevations in the anterior leads. So that would be V1, V3, and V4. The ST segments are way higher than 2 boxes, 2 millimeters, and they are concordant leads. So we said that V2, V3, V4 are concordant leads. So this is a ST segment elevation anterior MI, okay? Now, if the anterior wall is being hit, I'm going to look at the reciprocal changes. So I expect that the inferior wall is going to have the opposite changes in ischemia. So that means I'm going to go to leads 2, 3, and AVF. This is the inferior wall, and I should see ST segment depressions that supports my ischemia in the anterior leads. So let's take a look at 2, 3, and AVF, and you can see that the ST segment is depressed in them. So ST segment elevation anterior leads, ST segment depressions in the reciprocal inferior leads. This is obvious. This is definitely ischemia in this case. You might see situations where there's ST segment elevation without reciprocal changes. Okay, so pericarditis, for example, does that. The ST segments are elevated, but there are no reciprocal ischemic changes in the other, because it's not true ischemia, right? It's just the ST segments are elevated due to inflammation. Okay, so for me, this is a good way for you to remember it. Look for ST elevation, look for reciprocal ischemic changes. All right, so let's take a look at this one. Does anybody maybe, Puam, is it okay if you can maybe pick someone who can try to read this?
Yes, so of course, let's open it up in the chat.
Yeah, anybody
guys,
that
you can type in your answers, or if you want to, yeah, anyone.
Let's go with, maybe I could pick somebody that I know, one of the students. Dr. Naz, do you mind reading this one? Afshan Naz. Is Dr. Naz on?
You can, guys, you can put this in chat, your response. Okay, so I think we are getting responses in the chat.
Okay, so let me look at the chat then. Sorry, don't know how to do that with this. Sorry, Pawan. Okay. All right, so I just want to see if somebody can somebody unmute their mic and maybe read it.
So they will have to tell me at least.
They have to tell you. I see.
Yeah, because all of them are mute by
I got you.
participant.
Okay, no problem. So I'll take a read on it. Okay, so let's go through the same thing that we looked at, right? This is the rhythm, the rate here. If we look at the difference in QRS, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 300 divided by 9. So we would say that maybe in the 30s, the heart rate. So it's very low here. So significantly bradycardic. We can say that is it sinus? I look at the RR intervals. They are regular in between. I don't see clear P waves before every QRS. So the P waves are flattened here. Okay. And I see that the QRS interval is starting to widen, but clearly the T wave does not look normal. The T wave is very, very peaked as comparison to what we usually see. Okay. So this is, guys, another EKG that you must know as an intern. Okay. This is what hyperkalemia looks like. Hyperkalemic changes on the EKG are extremely predictable, and we'll go over them maybe in lectures in the future, but there's a specific order that happens to the EKG cycle as the potassium level rises. So the first thing that happens is that the T wave peaks. So we define that as that the T wave takes up more than 50% of the width of the QRS. So you can see that that's true here. Okay, so that's the definition of a peaked T wave. The next thing that happens is that the PR segment prolongs, then the P wave disappears, it completely flattens out, the QRS widens, and then the patient gets a sine wave and then codes. And these happen in exactly in that order. So for you, if you see that the ST, right now you could see that the P wave is gone, the T wave is already peaked. So the next thing you're expecting is that the QRS is going to widen. So for you, you should intervene before this happens. That means you're on the clock. You need to speed up. If I see a sine wave, I'm very worried. That means the patient's going to code very, very soon. You have to intervene very, very quickly. Okay. And these are obviously ischemic EKG changes that you should always be aware of. So here the answer is hyperkalemia. Okay. Let's do this one. So I'll give you guys maybe 2 minutes to type in the chat what you think this is. Let me see if I can see it.
Dr. Atoot, as we are waiting, a lot of questions about your MedComplete board review course, and also maybe you can also talk a bit about that after you're done with this part.
Yeah, as you guys are typing this, I'll let you know. So we have a course called MedComplete, and this is essentially where we stream all the lectures that we do at. I teach at 6 different residency programs for internal medicine and family medicine, and we at different hospitals in New Jersey. And we stream all those lectures live to all of you if you want to participate. They're done live via Zoom. So you will get the schedule on Sunday telling you, okay, we're going to lecture at Hackensack, St. Mary's, whatever it may be on those days with the Zoom link. You can join. It's a very highly academic environment, faculty's there, program directors, students, residents. It's high-level medicine. It really prepares you well for residency because you're sitting through what the lectures that the residents are learning to learn during residency. If you can't make it, then you can watch the recording. We record it and we give you access to it. And we give you access for 1 full year. If anyone is interested in signing up, you can just reach out to Pawam or myself, and we'll happily include you. Okay. Okay, so I think, let me just see the chat right here. Pericarditis. Yep, agreed. So this looks like pericarditis. Again, rate 1 box, 2 box, 3 boxes, 4 boxes, maybe 4.5. So the rate's normal. The RR interval is normal. I see P waves behind every QRS, so it's sinus. Okay. I'm looking at the segments, and obviously the ST segments are elevated. But notice the difference between this one and the last one. So the ST segments in V1, 2, 3, ST are elevated, but there are no reciprocal ST segment depressions in the inferior leads. The lateral wall has no significant reciprocal leads in the anterior wall. So this is telling you most likely this is diffuse ST segment elevation. With PR segment depression, this is pericarditis. This patient should be treated most likely with colchicine and NSAIDs, unless they have other conditions, but the standard of care is colchicine and NSAIDs now. Okay. Other things that give you ST segment elevations, guys, that are not STEMI, obviously pericarditis, ventricular aneurysms can also present with ST elevations, and Takotsubo can present with elevations, and Prinzmetal as well. So not everything is a STEMI with ST elevations, but that's the main thing you want to obviously exclude first. Okay. Okay. So Pawam, I think I'll stop here. Does anybody have any questions?
Yes, so this was very informative, Dr. Atoot. In fact, we get a lot of queries about how you teach during your rotations as well. So maybe you can give them a bit of an idea of how you run your rotations when you get students to rotate with you.
Sure. I mean, I think I try my best to create as an academic environment as possible. I think for some of you guys that may have worked with me in the past, you know that I really stress the idea of reading as much as possible, because ultimately, Pawam, the patients, they come to us, yes, for comfort, but they come for expertise. They come for your knowledge. And if you're a physician that does not improve your knowledge, I always say you're like a computer that doesn't update its software. Eventually, you're not going to work. So for me, when I work with the students, I constantly ask them questions. I test their knowledge to the point where, like, let's say they know AFib, they know types of AFib, maybe they don't know a particular portion of AFib, but that's where their knowledge stops. So I'll tell them, okay, this is the point where maybe your knowledge needs to improve. Let's go read about that together, or you read about it and I'll help you. And we see patients obviously of high complexity in multiple settings, and we're happy to take on students as much as possible, help them with learning, and give them support.
Again, to all of you, the good news is Dr. Atoot has agreed to help our students in the residency match process also. So when it comes to mock interviews and other help, he has graciously agreed. So he and Dr. Weissman will be there, and my team will send out links to you if you want to enroll for mock interviews or other advice. So that should be forthcoming. In fact, we'll send you, it'll be ready by the end of this week, so you can set it up as well. Otherwise, thank you, Dr. Atoot, for taking time out from your busy schedule. This was very, very informative. We had a lot of interaction. So thank you, and we look forward to other sessions from you.
Thank you, Pawam. Thank you, everybody, for having me. Take care.
Thank you. And guys, if you have any questions, I'm going to stay back about Dr. Atoot's course or anything else. So if you have questions, I'm here. So just type in, and me and my team will answer those. So anything about match, anything about rotations, research, we do have new match courses, which are very affordable. So Swati, maybe you can talk about that, at least save a link, send them a link for the turbo plan. And Soon Young is asking 1 more hour. Well, we'll have these sessions regularly. The best is if you missed anything, they are on our YouTube channel, so you can subscribe to those and keep following us. Any other question that I can answer for the season, for research, rotation, match, anything? When should I apply for pathway 6 if you're applying in September 2024? If you're applying in 2024, pathway information will open up in June of next year. Who should we reach out to regarding Dr. Atoot's course? So Swati can send a link. Swati had already posted a link. We'll take care of the enrollment. Follow that link and you should be able to enroll. It's a beautiful set of lectures, especially if you are an older graduate, these things really help. So Swati, maybe post a link again on the board review lectures of Dr. Atoot. Do you have any session for a personal statement? So we do have services for PS and CV review and edit, where you will get a review from physician as well as journalists. We did a free session, I think 2 weeks ago. It should be on YouTube. But of course, if you want personalized help, Swati can post a link to the CV Plus plan that we just opened. About the research plan, so Dr. Weissman offers manuscript research, case reports, and abstracts. So, Swati, you can put a link to that. Yes, thank you. How can I join research in cardiology? It'll be part of Dr. Weissman's research. You've already registered for rotation with Dr. Atoot in September, but you didn't get any email. My team will be able to get in touch. So Arthi, Delvi, if you send us your email, we'll be able to tell you the status. If you've already registered and paid, you should all be good, but type your email or send us an email at enroll@USMLESarthi.com. We should be able to help you. Any advice to send letter of interest to program director? So we have a lot of classes on this, but yes, as long as the letters are customized and personalized, demonstrating your interest, what you bring to the table, I think it'll be a good start. So Arthi, I hope you got her email. Delvi, who's registered with Dr. Atoot, she needs more information. So grab that email and give her the status, please. Okay, any other questions that you may have? Can we please send all these links in the email also? Yes, by tomorrow when this lecture goes out, you will get an email from us on the links for Dr. Atoot's lecture and everything. Yes, you'll get it within the next 24 hours. Any other question that we can answer for you at this point? What are some hands-on electives for students who have not graduated yet? So we have more than 100. Our main website, if you go, you can filter by those links, residencymatch.usmlesarthi.com. And maybe Arthi, you can put that link, residencymatch.usmlesarthi.com. So you should be able to filter, the location and for the specialty. What level of quality can I expect from Turbo Match plan? So Turbo Match plan is very similar to a Gold plan in terms of that you get all the classes, you do get our closed Telegram group, you do get your PS and CV reviewed by the physician and the journalist. So in terms of quality, your services are exactly the same as a Gold plan. The difference is this is all digital. So you're not attending a live classes, but you get the recording of the live classes. And B, it is more affordable. So if you want to add mock interviews later on, you can add it. Are there electives in emergency medicine that provide SLOE? So we are checking and we'll update our website for the emergency medicine rotation that provide this letter. Is the lecture series he mentioned to attend part of a paid tele-rotation? So he covers only part of the complete series in the paid tele-rotation. Obviously, the lectures are a different series altogether. They go year-round and they are across 6 hospitals. So it's a very good way for you to develop peer groups with other applicants as well as the current residents. Any hands-on for graduated students? Yes, all our rotations, or most of them, 99% of them are for graduate students as well. So the same link, residencymatch.usmlesarthi.com, should work. All right, any other questions for you all? If no, then thank you very much for attending. Remember, these are going to be, okay, last question. Can you explain a bit more about CV, Turbo CV Plus? So the Turbo CV Plus is a new affordable plan, given that the ERAS CV has changed. So you will get 2 classes for personal statement, 2 for CV, step by step explaining you how the new format has changed and what to put there. Plus, you will also get a complete thorough review of your PS and CV. Your CV will be reviewed twice, one by the physician, one by the journalist. Your PS will be reviewed 3 times, journalist, then physician, then again journalist. So it's a very affordable plan for those of you who are looking to quickly get their PS and CV reviewed with all the new changes. Step by step, very comprehensive. And I think Swati is putting what you can expect from that plan. So that's, if you want to do it and then maybe join other classes, that's fine too. Can you arrange a webinar related to whole math cycle? So we do a lot of webinars. So the whole math cycle also, there is a complete video on our website, but yeah, we'll be happy to do it after the math season ends. Assuming you are not applying this season. But yes, I mean, subscribe to our channel. Also, we put a lot of information on Instagram. Okay. All right. So thank you very much again. And what we'll do is we'll pick up the questions later on as well. But in terms of WFME accreditation, you should all be fine. If you've already registered, there will be no issues so far as we know. Okay, so I'm going to leave the links open for a few minutes, and then my team will also be in touch with you if you have any other questions and any issues, questions, etc. Let us know, as Swati has put those links. So thank you and have a wonderful day.